All right, wonderful. Well, it looks like we have quite a few people here and from all over the place, which is great. Everyone, everywhere from South Africa, Linda Rethman, who's our distributor in South Africa. Really appreciate you joining in. I guess it's in the evening or after dinner time there, Linda. And folks from all over the place. Now, it looks to me like there's people listening in that have both the consumer or personal devices as well as healthcare professionals, and that's perfectly fine. Just so everyone understands, when I use the term laser therapy and the second webinar I do every month is geared more towards healthcare professionals, only because I am also talking about using the laser probe, which personal systems do not have. However, a lot of the other information and so forth is still applicable if you have the home system as well. And certainly can ask me questions about that as well, too. Remember, these webinars are always recorded. They're eventually uploaded to our website under the support portal on our webpage. If you go to support and then find personal or professional webinars, you can find the archived webinars there. And as long as you register, you should be sent an email after the webinar. It usually takes a few days to a week with a link to it. And that usually is sent before it's even up on the website. So you can watch it again, or if you can't make it at all, then you can still get it sent to you directly so you don't have to go to the website. Okay. So I'm going to talk obviously about plantar fasciitis. I'm going to review the anatomy and then the epidemiology and pathophysiology and the etiology and signs and symptoms, many of which you probably know, some of which, you know, maybe a refresher or you weren't aware of, and then specifically how photobiomodulation therapy is going to help. Just give me 1 second here. Whoops. Okay, and then I'll discuss a couple of clinical research trials that use laser therapy. One in particular I thought it was interesting that also used shockwave therapy. And then it's specifically how you would use our equipment to treat plantar fasciitis. And of course, I always have time at the end for questions and hopefully an answer or two. Right, well, let's take a look at the anatomy. This, of course, is what the diagram of the plantar fascia looks like. It's a thick band of fibrous connective tissue, mainly collagen. It spans the arch right from the posterior tuberosity of the calcaneus. You can see where my sort of arrows are right there, all the way to the bases of the proximal phalanges of the foot. The plantar fascia originates at the medial tubercle of the calcaneus and inserts into 3 specific locations: the forefoot, and divided into the medial portion, the central portion, and the lateral portion. Now, this is important because only certain parts of the fascia tend to be involved with plantar fasciitis. Now, if you look at this diagram, you can see there's a medial band. That's in this purple area I'm highlighting right through here, and it inserts onto the muscles of the hallux, or the first toe. And then there's a lateral band, which is towards the base of the 5th metatarsals. Now, these 2 bands are typically not involved in plantar fasciitis. So again, when you're treating it, it's really important to treat the tissue that's most affected. And typically these thinner fibrous bands that don't do a lot of the support tend not to be involved. Now, there's a central band. This is the thickest part. It can be up to 4 millimeters in thickness normally, and much thicker when there's a pathology going on. And it's, of course, the strongest portion. You can see here it's divided into several bundles at the mid-tarsal level, and then each band sort of flares out and attaches to the plantar plate of the phalanges. So all of this in combination with the bones, they create essentially a truss or a support system for your arch. That's the main purpose of it, to give you spring and to support your foot. And then that translates all the way up in a kinetic chain towards your ankle, your knees, and your hip. So it's critical that your support system is working. Now, some people have, of course, flat feet or pes planus. And this is a problematic because they oftentimes would develop earlier onset of knee osteoarthritis and foot problems and so forth. And usually you want to be, even if you're not symptomatic, you want to correct that because it does reduce mechanical stress on these joints or these areas as well. So as I mentioned, it's responsible for raising and stabilizing the arch, especially during walking, and this is mainly during tensioning. The dorsiflexion of the toes that occurs during the terminal stance leads to tightening of the central band of the plantar fascia, which in turn then pulls the metatarsal heads closer to the calcaneus, and this increases the height of the arch. The arch itself is actually increasing due to this tension. Now, the medial longitudinal arch of the foot is sustained by the plantar fascia and certain subcutaneous structures of dense connective tissue. So you can see here that as the weight-bearing loading is coming down, that's translated and supported by the plantar fascia and secondarily by the Achilles tendon. Microscopically, the plantar fascia is dense, well-organized collagen. They're in parallel alignment. This is really important because it gives that really a viscoelastic mechanical property, kind of like a thick, strong elastic band. And this is the tissue that's affected in plantar fascia over a long period of time. And that's what makes it so problematic, number one, in healing and repairing, and why it can take so long and actually recur. So obviously it's a common cause of foot pain in adults, typically in adults. Of course, we know there's pain. This is usually quite sharp upon first walking in the morning or after a long or prolonged rest. Typical location is the plantar fascia insertion, and it can be unilateral or bilateral. It tends to affect both males and females relatively equal. You see a lot in athletes as well. I said equal, but I'm not sure why, but it probably has to do with angulations and so forth, that in females you may see a little bit more commonly. So even though the diagnosis and the way it's stated is an itis, which of course is Latin for inflammation, there's actually limited inflammatory cells that are going on directly inside the fascia. It doesn't mean there's not inflammation in and around the area, but the actual fascial tissue itself is more of a degenerative pathology. So in this degenerative pathology, sometimes referred to as a fasciosis. I don't know if I said that right or not. And obviously it's a typical overuse injury and usually due to repetitive stress, and this causes micro tearing. You can imagine that as you get older, everything gets a little stiffer and tighter, including collagen in different tissues and fascia. And so, then as you're active or maybe you go from periods of inactivity to activity, this is where you can start to get some tearing. Initially, maybe not symptomatic, but then you start to progressively get more and more symptoms. And then eventually it gets full blown and you have lots of problems. Increased fascial load is sensed by what's called gap junctions between cells called fibrocytes, which then mediates changes to what's called the extracellular matrix. And this results in what's referred to as a myxoid degeneration. It's kind of like a gel, you might say, and it starts to degenerate and fragmentate in the plantar fascia and the perifascial structure. So it's essentially, you just start to get a breaking up of your fibers. You start to get this mucoid or myxoid degeneration inside what would have been normal healthy fascia. So as a reminder, normal healthy collagen on the left, type 1 collagen, looks like parallel strands. And then type 3 or disorganized collagen, you can see it looks more haphazard, more like a spider's web. And if you actually looked at this under the microscope in plantar fascia, you'd see a lot of the fascia looking like this and not like on the left. So approximately 50% of patients with this condition also have heel spurs. And this is important because the number one, I think, mistake that clinicians and even patients talk about or maybe focus on is heel spurs. And oftentimes that's not causing the pain. It can, but oftentimes it's not. In fact, if you were to take x-rays of a lot of people that are walking around with zero pain, they have lots of heel spurs. So, and osteophytes or what have you, it's not painful necessarily. They can cause pain, but it's not necessarily the source of the pain. Now, when you're looking at the location of the pain, it can be located in the mid-medial arch, that's the orange area, the medial portion, and the mid-calcaneal portion or the fascial origin. So you see the red dot is the medial portion, and the yellow dot is the mid-calcaneal portion. And again, the mid-medial arch you can see is the orange. So those are the typical sort of painful locations. The actual cause of pain is we're not sure. When you talk about more of a degenerative condition and absence of inflammatory cells, and that goes for like tennis elbow, for example, where epicondylitis, you think, oh, it's inflammation, but oftentimes there's no inflammation, acute inflammation, but yet there's pain. And so there's different hypothesized reasons for that pain, but it's typically not inflammatory. But there can be an initial acute phase, especially of tearing, and this can then turn into a chronic phase. And so when you go into the chronic phase, you can then get this remission going on, and you get progression and fascial degeneration process. The incidence of plantar fasciitis in runners is relatively high, almost up to 10%. And it's the third most common injury after shin splints and Achilles tendinopathies. You'll see this way more in, I'm going to say, a little nutty ultra marathon runners. I say that because I don't know. I don't see the point of having to run 100 kilometers or what have you. Just run 10 kilometers, will you? But if you run ultra marathons, you're more prone to lots of other injuries. And plantar fasciitis is one of them. Maybe if you're an ultra marathoner, you can chat me up a little bit and tell me about the benefits of running ultra marathons. There's lots of risk factors. Now, there's intrinsic risk factors. These are mechanical or functional or degenerative issues from high arch, low arch, leg length discrepancy, overweight, what's referred to as torsion of the tibia. So it's kind of an unusual rotation of the tibia, or even similar to the femur. And this is sometimes where women tend to get it more because they have different torsions, just anatomically, that's how they are. That have to do with childbearing. And then if you have tightness of muscles, so this is important to pay attention to, because part of the rehab and preventative things should be ensuring that muscles like your gastrocs and soleus are not super tight. And same thing for the Achilles. And so when you're treating plantar fasciitis, you'd be recommending stretching. In fact, you could even do some treatment of the gastrocs or soleus or Achilles as well, especially if you're noticing issues there as well. And then, of course, there's degenerative issues like the heel fat pad. As we age, it gets less shock absorption. It reduces in thickness. So that kind of thing. Then there's extrinsic factors. You can imagine like incorrect training, too far of a distance, intensity or duration, those kinds of things. One of the key things is inadequate footwear. And before you run off and buy a $400 pair of shoes, I'd highly recommend that you chat with someone really knowledgeable, not a 17-year-old working at a shoe store to give you recommendations on that. I would definitely talk to someone that knows what they're doing. Preferably if they have some assessment tools, that would be really important. Maybe see a chiropodist or podiatrist to get a really good professional opinion. There's other things that can cause pain in this area, everything from neuropathies and what's referred to as tunnel syndrome issues, neuromas, even tears, but usually that's happened, rheumatological conditions, those kinds of things. So it's important to get a proper diagnosis. Now you can do an ultrasound, by the way, and they can kind of actually measure and look at the thickness of the plantar fascia. Most doctors don't do that because they'll just say, oh, you got plantar fasciitis, and usually they're correct. But it's helpful because if you get an ultrasound, you can know where you're at with the thickness and then get it done, say 2-3 months later and see if it's improving. It's a cheap test, so I would recommend that as well too. Usually plantar fasciitis is self-limiting. I say that usually because 90% of people are going to be much better within 3 to 6 months of conservative treatment, but sometimes it doesn't work that way. Sometimes it can take longer, a year or longer, recur, that kind of thing. And, doctors will prescribe NSAIDs, which is not, I don't think, recommended. They'll, physios and so forth will talk about stretching, which is good, maybe heel orthotics or heel pads, heel cups, those kinds of things. There's night splints. Some of them may help, some may not. There's no definitive answer on some of these things. And just so you're aware, I wouldn't run out and get NSAIDs. Number one, it's not an inflammatory issue unless it's traumatic. So you're wasting your time and money with that typically, and prolonged use of NSAIDs can lead from acute to chronic issues as well. So definitely not recommended. Orthotics decrease the heel rise. So that's important as well, and this can help to reducing pain. So prefabricated, custom fitted, those kinds of things is what you should be looking at. My preference are custom fitted with someone that knows what they're doing, as opposed to off the shelf. But sometimes off the shelf work. I know Birkenstocks, if you find the right one, they're quite effective as well too. But I don't know. I mean, you may not necessarily want to go out in Birkenstocks when you go out to a nice dinner, but maybe. Immobilization, night splints, there's these walker boots, those kinds of things. So a night splint is basically, you can see a picture of it here. It prevents plantar fascia contracture by maintaining a neutral position. And night splinting is most effective in patients where the chief complaint is morning pain. Their use is often limited because it's kind of hard going to sleep with this massive thing tied onto your leg. It's not very comfortable. You probably don't get very good sleep. And there's a clinical review that showed night splints used in conjunction with custom foot orthotics. It can help with pain relief. So, if you can tolerate it, then I suppose you can give it a whirl. But it's not easy. Stretching of the gastrocs, that's very important. You need to understand how to do that. I'm not going to go into any details. Make sure you understand how to do it, how many repetitions, those kinds of things. It is really important. And stretching of the plantar fascia also plays a crucial role just by itself as an effective treatment for chronic plantar fasciitis. So here I've shown a diagram, I don't know if you can see it here, where in the plantar fascia stretch, the foot to be stretched is placed on top of the contralateral knee, so the opposite knee, and the ankle is maximally dorsiflexed and the toes are pulled up, tensioning the plantar fascia, and is then gently massaged along its length. Shockwave therapy, I like shockwave actually. Not everyone can tolerate it. It really works well in conjunction with laser therapy. If I had to choose one or the other, I would go with laser for sure, because I'll show you the evidence on that. But definitely, if you're a practitioner out there and have shockwave, do shockwave and then do laser therapy. I think that you would get much better results overall. Whoops, went by that one. Corticosteroid injections, no. Again, they're really getting away from cortisone injections, corticosteroid injections. They actually inhibit fibroblast proliferation. They cause lots of long-term issues. It's not an inflammatory condition. So any doctor that says, oh, let's do a steroid injection, number one, is completely out to lunch. I would never get it done. Research doesn't support it, and they probably went to school 50 years ago, or they haven't read any research. PRP is an up-and-coming type of therapy. That's platelet-rich plasma. Funny, I was reading an article, a bit of a baseball fan or sports fan, and I don't know if you're aware, there was a player who injured their first toe and jammed it up against something, couldn't play. And then I was just reading that he was responding. As Judge is the name of the player. I don't know why I forgot it. And it actually really helped on the PRP. They're probably doing laser therapy too. I don't know if they have BioFlex, they should, but the PRP really helped them. So I think if you can try, if you have the ability to try it, there's a bit of a cost to it, obviously, but there's ongoing research to show that it helps tissues recover faster. Not a lot of research out there yet, but I think it might be worth a try. As far as photobiomodulation and light therapy goes, then we know that the research context talks about it improves collagen fiber organization, maturation, secretion. It downregulates something called MMP, which MMP actually degrades proteins in the matrix that holds the tissue together. So that's a good thing. And if there's any inflammation around, if there's an acute scenario or other tissues around that are inflamed, it will help reduce inflammation as well and decrease pro-inflammatory mediators. It can do other things with respect to helping proliferation of cells and matrix remodeling, like upregulating, which just basically means that the DNA that makes insulin growth factor and these proteins that are produced is upregulated, so you see more production of them. It can reduce fibrosis, and it has a short spike of what's called ROS, which are reactive molecules, oxygen in this case. And these are really important in cell signaling and regulation of what's called cell cycle progression. All that means is that it speeds up the ability of a cell to undergo mitosis or regenerate. Therefore, got one cell, you're going to split into 2 cells and 3 cells and 4 cells, and therefore you'll get repair going on faster. That's really one of the number one ways that photobiomodulation is helpful in tissue repair. Research-wise, this is the one I mentioned that also looks at shockwave. They also looked at ultrasound and laser therapy for plantar fasciitis. It was a randomized control trial, and there was 3 treatment groups: one that got laser, one that got continuous ultrasound, and one that got extracorporeal shockwave. I think it was around 2,000 shocks. And they looked at visual analog scale, like from a 0 to 10, how painful it is, and they would check that. And they did other index, patient would fill out different things, how they could walk and so forth. And they did MRIs before and 1 month after. And overall, they found that success rate was about 71% for laser, 65% for shockwave, and much, much lower with the ultrasound. So if you're a practitioner, you got all these devices, the research is saying, hey, do laser if you're going to do anything. But again, if you can do more than one, I would do laser and shockwave. Preferably do shockwave first and then laser right after to help. And then if you have ultrasound, fine, you can do it, but I don't think it's going to do a lot. This one was a meta-analysis and systematic review. So this is where they take a whole bunch of randomized control trials that were previously published, and then they looked to see it. So they looked at tons of studies, and they settled on 7 randomized control trials. And then from those 7, 4 were intensively meta-analyzed. And the overall effect of PBMT was statistically significant, favoring for the thickness of plantar fascia reduction. So the thickness of the fascia decreased, which is what you want with laser therapy. So they concluded that there's evidence to suggest that photobiomodulation is effective to reduce pain, improve foot function in patients with chronic plantar fasciitis, but there's still a broad discrepancy in dosimetry or parameters. And that's the hard part. To be honest, one of the things I always say is that if it's not working, you have to try different dosaging. That could be the treatment time, the power, those kinds of things. When you start playing around with that, then you will find what works. So don't give up. Try different stages or levels. If you have a home system, if you have the professional system, you can customize a duty cycle, those kinds of things. But you can also play around with the laser probe as well. So placement-wise, this is what I typically recommend. Roll up a nice towel and then place the array on top of the towel. You can use this whether it's a home system or a professional system, and then place your foot so it's curled up, so the arch is nice. and it makes good contact. It's really important to make good contact. It's also really important not to have any creams or oils, excuse me, on your foot, because that can actually deteriorate or gum up or, affect the way the light's coming out of the diodes. So try not to have, just don't put your peppermint foot cream on before a treatment. You can do that after kind of scenario. Then the second placement, I do another one, and you kind of curl it behind the heel and around the Achilles, because remember the Achilles is also involved as well too. And when you're wrapping it around, you get good coverage of the insertion, or I guess more the origin of the plantar fascia on the posterior calcaneus. We do have a specific protocol that was developed for decades here in the clinic and by the late Fred Kahn. You can see here, we use red for about 5 minutes. We use near infrared. It starts at 10 pulses per second and 30% duty cycle, which is a pretty low pulse rate and power, or I guess dosaging. And you can see there's about 6 minutes of the infrared probe, and then you can start to see as you go to farther, or like later stages, the duty cycle starts to increase a lot more energy. But it's important to start pretty low and see how your client responds. Now, probably the most critical part of the treatment, if you're a healthcare professional using our professional equipment, is targeting the tissue that you know is involved. So try not to use a laser probe extensively on areas that really aren't problematic, or doesn't make sense to do it. And the laser probe is the part of the equipment that really does the accelerating of the tissue healing. So you want to focus it on the on the origin of the plantar fascia. You can see here, this is the area of the origin on the posterior calcaneus, and then along the length of the fascia, whether it's on the medial aspect or lateral aspect, wherever you're finding the patient's complaining of pain, but also with palpation. Those would be the areas that you're going to target. Once you've held it for a certain time frame, I'm going to recommend initially 5-6 seconds, but you may want to increase the amount of time, even up to 10, 15, 20 seconds. Think about this. Near the heel is the thickest, 4, 5, 6 millimeters in thickness, depending on how chronic it is. But then as it starts to spread out, it gets thinner and thinner, so you don't need to use as much time. So, it's really important when you're doing lasers, you're thinking about what you're doing and not paying attention. So hold it for longer over the thicker areas of tissue and hold it for less over the thinner part of the tissues. And that has to do with, we know that there's a window of dosage that's most helpful. And the deeper the tissue is, then the longer you need to treat to allow enough dosage to make it to that area, to have enough dosage to cause this photobiomodulation effect. Treating it really quickly or shortly won't do anything. And that's really important. Treating it way too long doesn't have the desired effect either. That's why you may need to play around with it, and that's okay. But once you're finding what works best, then you can focus in on that. And that's easy to figure out because the patient will tell you how they're responding. And of course, you're going to be following up every time you see them. Also important to hold the probe perpendicular to the tissue and gently push in. Don't hold it at an angle because the light will reflect off. And remember, you're always going to be using the safety goggles, the safety glasses, and your client will, or your patient will as well, when you're using a laser. So that's really important. So as I mentioned, you want to hold the probe for upwards of 20 seconds. Again, depending on where you are, if it's thick or thin or what have you. Then once all the points are treated on the fascia, you may have a little bit of time left, or maybe you want to treat trigger points in the gastrocs or soleus or tenderness in the Achilles. Oftentimes you get Achilles issues going on at the same time. So if that's a problem, treat the Achilles as well. If you have a red laser probe, that's a LDR 100, then this is very helpful for analgesic effects. Another point I want to mention is that this area is notorious for callus formation. and the laser probe may not trigger on easily because of the callus. If that's the case, then use your finger and touch the side of the probe, and that will trigger it on. So that's just a little tip to engage power if you're finding the callus is preventing it from turning on easily. If you can treat 2, 3, 4 days in a row, that's ideal. But if not, 2 to 3 times a week initially is kind of what I'd recommend, and then slowly start to reduce frequency. That might take several weeks, because usually, and it's important to tell your client or your patient or understand that for them to be symptomatic means that there is long-term damage there, not a few weeks, not a few months, probably years. So, it's not going away overnight. And if they understand that and they work at it and do the stretches and everything else, they will get better. But if they're not compliant, they make crappy patients. They're not going to have good results. You're not going to get a good Google review. So, be clear with them. And if not willing to do the work, then say, I'd love to take your money, but you're wasting your time because you're not going to be compliant. You have to be pretty strict with your patients. Overall, it may take up to 24 treatment sessions, several months. That is true. But usually you start to see pretty good results within a month, and the patient's pretty encouraged by that. And you have to make sure they're behaving themselves and not going out for their ultra marathon after treatment. Doing shockwave, do the shockwave, then follow it up literally right after with laser therapy. That's what I'd recommend. Upcoming events. Wow, this is pretty exciting. So we have a masterclass coming up on July 8th. If you're not in the area and can't make it in person, I really hope you can, because number one, we're doing on sports injuries, and we have some great speakers, Dr. Ben Ewan and Dr. Randy Santiago, and we're going to be showing how to use our equipment to treat concussions. Of course, related to sports injuries, but any type of concussion, that's what Randy's talking about. So we'll have a practical session on using our equipment and understanding how to do that. So those of you who are interested about that end of things, that's really important. Ben will be talking about, I think, shoulder tendinopathy and ACL in the knee. I'll be doing one on sprains, and Slava Kim will be speaking as well. And we also have David Barker, an RMT from Kingston, who'll be talking about a post-surgical recovery and a wrist fracture related to sports. So it's a great event. It's still early bird. I think it's around 1:49. You get a nice lunch and it's the whole day. But really what's cool is that we're going to be releasing a new line of consumer devices. And a little sneak preview, this is the logo. And it's really interesting because we've done a lot of homework. I've done a lot of homework to understand what's out there. It works a little bit differently. I'll tell you right now, we're not necessarily using these devices to treat plantar fasciitis, but we are using it for other things. And if you'd like to learn more about that, join us for the masterclass. You can actually watch remotely too and sign up remotely. You just don't get a free lunch. Sorry about that. And however, I'm also doing a webinar on this very topic on July 13th. That one, I'm going to say definitely join in, because I'll be giving away free to some of our viewers like you, some of these devices. So if you're interested in it, please join me then, but preferably the masterclass, because I think that will be really good information. I also have a webinar on stem cell stimulation using laser therapy. That's in July as well. And the information on our webpage, go to education, go to masterclass, and you can sign up. You can see here it's $149 Canadian. If you live in the United States, that's like $5 US, so it's pretty cheap. What else do I have here? Let's go to questions. All right. I don't know if I see any. Oh, here's a couple questions here. Why shockwave first and then laser after and not the other way around? That's a good question. Because shockwave by its nature is disrupting tissues. It's actually breaking down collagen. It's breaking down tissues and causing really it's causing tissue damage. And so what light therapy does is it facilitates the healing of that tissue damage, as opposed to letting your body do it. So it's best to do the shockwave. Then you're disrupting the tissues. It sounds kind of awful, but that's really what it's doing. And then the body's trying to heal it up, right? But the light therapy actually accelerates that healing process. So I have a question here. If someone has strained their foot and experiencing pain at the top of their foot, would the protocol setting be the same? So, yeah, so the probably what happened there. So no, so the setting I would use there is the ankle and foot setting. And I would put the array over the top of the foot. And if there's any issues on the bottom, treat that as well. It's probably a joint sprain or injury to the mid-tarsal joint, but you'd have to figure out what's going on. Point here, I happen to know someone does ultra marathoners, and it appears that most of them use running as a way to manage ADHD. Okay. You may have already mentioned it, but I found that incorporating foot and toe exercises into the client's self-care routine can yield positive results. That's awesome. So yeah, no, I'm kind of joking a little bit with ultra marathoners, but and in fact, that may be correct. It just seems an extreme way, but I know they know what they're doing and everything, but man, it can put a lot of mechanical stress. I know a lot of ultra marathoners that have had to stop because of issues, especially around their hip and their knees. Oral collagen supplements. I don't know. I don't know about that. I think glucosamine and chondroitin sulfate. I think there's some evidence to suggest that. I don't know about collagen. Maybe. I haven't really looked into it. So unfortunately, I don't have an educated opinion on that. And I would always reference the research if I would recommend something. Can diabetic neuropathy be treated the same as plantar fasciitis? Hi, Jill. No, so you know what, diabetic neuropathy, I wouldn't use, well, first of all, I wouldn't use this protocol, and I wouldn't use laser probe. I would treat the lumbar lumbosacral region in conjunction with the area where there's neuropathy. The red light is probably what's going to be the most beneficial. So you might want to increase the red light by a minute or two using continuous wave, and then infrared after, maybe like, I don't know, 20/50 or something like that would be helpful. But just the array, and you have to be consistent with it. It does take a lot of time for repair of the vasculature to the sensory nerves. All right, let's see here. Comment here, I've had plantar fasciitis, but had physio-induced stretches. I think it's healed, no pain, but would it be good to use my laser? It's 10 years old to ensure it's gone. I have arthritis at the top of my same foot. Should I use laser on my arthritis? Hi, Sherry. Yeah, definitely. There's no harm in using the laser therapy for that. And you want to do it preventatively, because I'm assuming you're probably not 20 years old. So definitely continuously use it, because even if you're not symptomatic, it will be helpful. Okay, that's it. Thanks again for joining in. Well, why is this syndrome not associated with the tendon connections to the phalanges? Why is this syndrome not associated with the tendon connections to the phalanges? I think really that has to do with the fact that most of the tension is in the mid portion of the fascia, and where it originates, a mark in the heel. That's where most of that mechanical stress is relayed. By the time you get to the phalanges, there's not as much stress, mechanical stress. So I don't think that's typically why you'd have a lot of issues in that portion. It's more usually the mid portion or the sides or the back. That's typically where it is, and I'm assuming that's kind of why. Yeah, the ultramarathoners make great clients, but they have lots of injuries. I know, I agree with that. I would use the foot protocol for Morton's neuroma for sure. That's a tricky one to treat as well. Wonderful. Thanks for joining me. And again, if you haven't signed up for the masterclass, please do so. I'd love to see everyone out there. It will be really exciting. I think you'll find the stuff that we're going to be releasing will be really cool and pretty affordable too. So yeah, so if you have a chance, join in. We'll be doing giveaways as well on the masterclass, and for the people that are listening in remotely on the masterclass. So there'll be lots of that. And if you come, there should be giveaways as well, although we're working hard to figure that out. So I don't want to speak. That's just a little secret. Don't say anything. All right. Have a great day, everyone. Take care. Thanks for joining me, and we'll chat again soon. Thanks.